Welcome to This Week in Neurosurgery. This week we're covering 10 notable papers spanning spinal reconstruction, neuro-oncology advances, and surgical complications. Let's dive in. Beginning with spinal cord injury and deformity management, regenerative and reconstructive frontiers are moving forward. In a landmark first-in-human Phase 1 trial, Sugai and colleagues evaluated induced pluripotent stem cell-derived neural stem and progenitor cell transplantation in 4 patients with subacute cervical complete spinal cord injury. Over 2 to 4 years of follow-up, the primary safety endpoint was successfully met with no tumor formation or graft-related adverse events and stable graft sites on imaging. Exploratory efficacy showed a median motor score improvement of 13 points, with 2 patients improving from American Spinal Injury Association impairment scale, grade A to C or D, gains numerically greater than spontaneous recovery observed in a registry-based cohort. Turning to complex adult spinal deformity surgery, 2 studies in neurosurgery examined bone morphogenetic protein use and opioid optimization. Okonkwo and colleagues performed a retrospective cohort study of 288 patients undergoing deformity surgery of 5 or more levels and found that intraoperative recombinant human bone morphogenetic protein 2 independently reduced the risk of pseudoarthrosis or rod fracture from 38% down to 16%, with an odds ratio of 0.14, without increasing nerve root inflammation or wound complications. Subgroup analysis demonstrated specific efficacy in patients with obesity and osteoporosis. Complementing this, De Oliveira and colleagues investigated preoperative opioid weaning in 67 chronic opioid users undergoing adult spinal deformity surgery, reporting that complete weaning accelerated time to postoperative opioid freedom by nearly 5-fold, alongside a dose-response trend toward lower mechanical reoperation rates. Exploring healthcare disparities and institutional differences in spine care, Khan and colleagues compared outcomes between a private and a neighboring public hospital affiliated with the same academic center for spinal metastasis surgery. Patients treated at the public hospital were significantly younger, more frequently of Black or Hispanic race, uninsured, and presented with higher-grade epidural spinal cord compression and profound motor deficits. Yet multivariate analysis revealed no significant difference in overall or progression-free survival between the institutions, underscoring critical inequities in early access and referral structures. In neuro-oncology, surgical decision-making, radiation strategies, and tumor characteristics heavily dictate functional trajectories. DeMonte and colleagues evaluated 60 patients undergoing resection of brain metastases in motor regions, finding that new postoperative motor deficits occurred in 16% of cases, though half recovered by 30 days. Crucially, persistent or worsened postoperative arm deficits were associated with substantially decreased overall survival, highlighting that upper extremity neurological preservation is a major determinant of survival outcomes. Shifting to intracranial meningiomas, Maata and colleagues conducted a 19-year retrospective analysis of over 2,200 primary resections at Helsinki University Hospital, published in the Journal of Neuro-oncology. Despite rising detection rates and an aging population, age-standardized surgical incidence significantly declined over time as prophylactic surgeries decreased and operations became increasingly restricted to cases with documented growth, large size, or functional deficits. In low-grade gliomas, Wojciech and authors analyzed 143 patients treated with intensity-modulated proton beam radiotherapy and found that each additional cubic centimeter of planning target volume significantly reduced the patient's likelihood of returning to full-time employment by 0.5%, emphasizing that minimizing irradiated brain volume is essential for preserving work capacity. For previously irradiated brain metastases presenting with progressive lesions, Marshall and colleagues evaluated the value of surgical resection in the Journal of Neuro-oncology, revealing that histopathology demonstrated true tumor recurrence in 68% of lesions, while 84% of recurrences showed mixed pathological features. Surgery provided profound symptomatic improvement with high rates of corticosteroid discontinuation, regardless of final pathology, and pure radiation necrosis was associated with a markedly longer median overall survival of 39 months compared to 19 months for tumor recurrence. Addressing neurovascular emergencies and surgical technique, 2 papers evaluated acute stroke intervention and cranial reconstruction. Claren Khan and authors reported the results of the discount randomized clinical trial in JAMA, which evaluated mechanical thrombectomy versus medical treatment alone in acute ischemic stroke from medium or distal vessel occlusions across 22 French centers. The trial was halted early for futility and increased safety risks after 244 patients were randomized. Thrombectomy did not improve good functional outcomes at 3 months, achieved in 62% of the thrombectomy group versus 68% of controls, and was associated with significantly higher rates of symptomatic intracranial hemorrhage at 11% versus 3%, subarachnoid hemorrhage, and embolus migration. Finally, in operative neurosurgery, McCormick Ince and colleagues introduced the SMART-C incision for decompressive hemicraniectomy, designed to preemptively optimize future alloplastic cranioplasty. In their consecutive case series of 11 patients followed for over a year, 0 cranioplasty-related complications, wound infections, or breakdowns were observed, and every patient achieved a Grade 1 cosmetic outcome. If you only have time for one paper this week, make it the discount trial by Clarencon and colleagues in JAMA. This prospective randomized multicenter trial provides vital level 1 evidence halting the unselected expansion of mechanical thrombectomy into medium and distal vessel occlusions, demonstrating no functional benefit and a significantly increased hemorrhagic risk. Here are the key takeaways from this week in neurosurgery. First, human iPSC-derived neural progenitor cell transplantation in subacute cervical spinal cord injury demonstrated long-term safety without tumor formation and promising exploratory motor recovery. Second, recombinant human bone morphogenetic protein 2 significantly reduced mechanical fusion complications in high-risk adult spinal deformity patients, particularly those with obesity and osteoporosis, without increasing local adverse events. Third, complete preoperative opioid weaning in adult spinal deformity accelerated postoperative opioid freedom by nearly 5-fold. Fourth, mechanical thrombectomy for medium or distal vessel stroke occlusions failed to improve functional outcomes and increase symptomatic intracranial hemorrhage rates in the discount trial. Finally, surgical resection of progressive irradiated brain metastases offers high diagnostic accuracy, substantial symptomatic relief, and excellent corticosteroid withdrawal, irrespective of whether the lesion represents radiation necrosis or true tumor recurrence. That's your roundup for this week in neurosurgery. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.